slide compares and contrasts cyclooxygenase 1 and 2. COX-1 is expressed constitutively for housekeeping functions, whereas COX-2 is primarily inducible. It's constitutive in some tissues, though. Location, COX-1 pretty much everywhere, COX-2 mostly in inflamed tissue. Substrates for COX-1 are arachidonic acid and EPA, whereas COX-2, in addition to arachidonic acid and EPA, can also act upon alpha and gamma linolenates. Role for COX-1, as we said, housekeeping. Role for COX-2 is pro-inflammatory and mitogenic. Induction is rare for COX-1, although it can be induced by human chorionic gonadotropin during pregnancy. COX-2 is induced by inflammatory cytokines. Inhibition, COX-1 non-selective COX inhibitors like NSAIDs and aspirin, whereas COX-2 is inhibited by glucocorticosteroids, interleukin-1 beta 4, 10, and 13, NSAIDs, and selective COX-2 inhibitors like celecoxib. We'll soon see that we have non-selective COX inhibitors, COX-1 selective inhibitors, and COX-2 selective inhibitors. When we selectively inhibit COX-1, we'll see that blocking formation of thromboxane A2 leads to an anti-platelet aggregatory effect with the risk of GI bleeding from mucosal erosion. When we selectively inhibit COX-2, we get antipyretic, anti-inflammatory effects, pro-aggregatory effects on platelets because we lose prostacyclin, and we get vasoconstrictive effects. Notice there's much less risk to the GI tract. Aspirin is unique in that it irreversibly acetylates cyclooxygenase 1 and 2 to produce primary beneficial actions. In the hypothalamus, we get anti-fever effects. In the periphery, we get reductions in inflammation. In neurons, we get decreased sensitization of our pain receptors and also decreased central pain processing to produce analgesia. Importantly, when we block COX-1 in the platelets, remember they have no nuclei, we decrease formation of thromboxane A2 to get an antiplatelet aggregatory effect. Remember, our vascular endothelium expresses COX-2, which is also blocked by aspirin, but the vascular endothelial cells have nuclei, so they simply make more COX-2. Other cyclooxygenase inhibitors produce these effects in varying degrees, though they do it through reversible blockade of cyclooxygenase 1 and or 2. There's some other important effects of aspirin that we need to talk about. First of all, aspirin is going to uncouple oxidative phosphorylation. It's going to uncouple the electron transport chain in the mitochondria. The body's going to respond to the lack of ATP with an increased respiratory drive and hyperventilation. Blowing off CO2 causes a respiratory alkalosis. At the same time, we'll see a switch to anaerobic metabolism when oxidative phosphorylation is broken, so we see a simultaneous metabolic acidosis. When we block cyclooxygenase, our arachidonic acid is now free to go down the lipoxygenase pathway. People with susceptibility can have bronchospasm from increased leukotriene formation. In the GI tract, as we already mentioned, there's a risk of gastric ulceration. For your information, low-dose aspirin can inhibit secretion of uric acid, which may cause gout in susceptible individuals. Reye syndrome is a rare but serious side effect of aspirin in humans. When given to pediatric patients with viral illness, aspirin can cause an acute non-inflammatory encephalopathy. It's associated with hepatic dysfunction and fatty degeneration. It's probably due to an underlying disorder in metabolism. Signs and symptoms include protracted vomiting, delirium progressing to coma, seizures, decerebrate posturing, hyperventilation, and enlarged liver. In addition to decreasing sodium and water retention, prostaglandins help maintain dilation of the afferent glomerular arteriole, which is really important when renal arterial stenosis or cardiovascular disease limit renal blood flow, or when hepatic cirrhosis, heart failure, or excessive diuresis lead to loss of circulating blood volume. This loss of perfusion pressure can both reduce filtration pressure and cause relative renal hypoxia. Low-dose aspirin is unlikely to cause significant alteration of renal hemodynamics. Adverse effects of aspirin and NSAIDs depend upon which isoenzymes inhibited. When we selectively inhibit cyclooxygenase 1, we have an increased risk of antiplatelet effects and GI ulceration, which increases the risk of GI bleeding. When we selectively inhibit COX-2, we see a much greater effect at risk of thrombosis because we're blocking formation of prostacyclin more than thromboxane A2. Both COX-1 and COX-2 inhibition can cause nausea, stomach pain, changes in renal perfusion, sodium and water retention, hypertension, and bronchospasm, which might be seen as an anaphylactoid type of reaction, where bronchospasm occurs without hypotension. Some important contraindications to aspirin and NSAIDs include active GI bleeding, diminished renal function, allergy or hypersensitivity, including a history of that anaphylactoid bronchospastic type of reaction to aspirin or NSAIDs, risk of thrombosis, particularly with those agents that are COX-2 selective. In pregnancy, if we give aspirin or NSAIDs late in the third trimester, we risk premature closure of the ductus arteriosus. Liver, other kidney disease, dehydration, lack of access to water similarly are contraindications to NSAIDs. There are also several drug interactions that we need to think about. Most are due to effects on renal function and platelets. Moving on now to acetaminophen or Tylenol, whose generic name is paracetamol in other countries. We don't really know how this drug works. It produces its effects only at the level of the CNS. It produces anti-fever and central analgesia. Adverse effects: minimal platelet effects, so it's relatively safe with anticoagulants like warfarin and heparin. It does not have bronchospastic respiratory effects. It doesn't produce renal effects, but unfortunately it's also not anti-inflammatory. Acetaminophen forms a toxic metabolite, N-acetylparabenzoquinonamine, NAPQI. Stage 1 in toxicity, up to 24 hours post-ingestion. Kind of generic symptoms: anorexia, nausea, vomiting, malaise, diaphoresis. Stage 2, 24 to 72 hours post-ingestion. We probably see resolution of stage 1 symptoms, but here's where hepatic damage is occurring. We'll see right upper quadrant tenderness, decreased urinary output, perhaps pancreatitis, elevation in liver enzymes, maybe increase in PT-INR, etc. Stage 3, 3 to 5 days post-ingestion, we're starting to see our stage 1 symptoms reappear, but now also we see the evidence of hepatic damage: jaundice, hypoglycemia, bleeding, and perhaps even death. Stage 4, 5 to 14 days post-ingestion. If the patient didn't die, they'll probably recover, though they may need a liver transplant. Chronic consumption of alcohol can increase the rate of toxification of acetaminophen. Chronic alcoholism induces cytochrome oxidase P452E1, and it can also deplete glutathione stores through malnutrition. When CYP2E1 is induced, we have a greater rate of formation of the toxic metabolite N-acetylparabenzoquinonamine. The specific antidote for Tylenol toxicity is N-acetylcysteine. It helps to replenish glutathione stores. N-acetylcysteine, Mucomyst, is the specific antidote for acetaminophen toxicity.